Enthused to talk about where we are in 2020, but a very personal reason for entitling it that way. I have no relationship with commercial interests. I am a clinician educator with the Royal College of Physicians and Surgeons of Canada. And my hope is at the end of this presentation, you'll know a little bit about the field of study of physician wellness, and then we'll touch on the implications for education and practice. I'd like to talk to you about a project that I've been involved in for the past 2 years with the Royal College, and then bring it closer to home and think about some work that we've been doing at the School of Medicine here at Queen's. Physician health and wellness, and as I said, I put the title, I called it Where Are We in 2020, but really it's Where Am I in 2020? It's all about me. And the reason I was thinking about that is because it came to my attention when we came to 2020 in the new year that I have been working in physician wellness since 1995. I've been doing this work for 25 years, and I thought it was an opportunity for me to reflect on what's happened in those 25 years, both in the field, because the field has changed dramatically, in the field, and then the work that I'm doing. So, although I've been doing it for 25 years, actually, Galen, who lived from 129 to 210 AD, a Greek philosopher and physician, said, that physician will hardly be thought very careful of the health of his patients if he neglects his own. So this is not new, but in terms of physician health as a field of study, it really began in about the mid-1960s when it became apparent that physician addiction, and it was called addiction at the time, was higher in physicians, so addiction was higher in physicians than in the general population. It was about 15% in physicians at that time, compared to the general population of 13%, and so people became understandably quite concerned about that. But since the mid-1960s, a lot has changed. Physician health programs were developed across the US and across the provinces. We have physician health programs in every province now in Canada. And as physicians started accessing those resources, people became aware that, not only addiction, but depression and anxiety. In the 70s and 80s, that was really the focus. In the 1990s, it became apparent that new terms started to be used. Compassion fatigue entered the literature, and vicarious traumatization. So it has evolved until the 2000s, when the word that is used when we speak about physician health and wellness, or lack thereof, is burnout. Now this came about after Maslow and Leiter wrote their book in 1997, where they really outlined what work-life troubles are, and they described it as burnout. They weren't the first to coin the phrase, mind you. That was in 1974, but they were the first to speak about workplace ill health, call it burnout, wrote their first book in 1997. And ever since then, when we talk about physician wellness, we're thinking about burnout. So, what is burnout? Maslow and Leiter, in their book in 1997, described it as a psychological syndrome emerging as a prolonged response to chronic interpersonal stressors on the job. Subsequently, a more detailed or sophisticated definition came out, which is a work-related syndrome that occurs in occupations where others' needs come first and where there are high demands, few resources, and a disconnect between workers' expectations and their experiences. So the crucial thing to think about when we use the word burnout is that it's an occupational syndrome, and it is not a diagnosis. Now, having done lots of reading in preparation for this topic, I learned that actually in Sweden and the Netherlands, it is considered to be a diagnosis. So if you go to a physician and you can be diagnosed with burnout in those two jurisdictions. But otherwise, we think of it as a syndrome. And the syndrome has three domains. Emotional exhaustion, which is really a sense of feeling completely drained, having a loss of enthusiasm for your work. The second domain is called depersonalization, and many people can't get their heads around what does that actually mean. And when the word is used, it means detaching from your workplace and really an attitude of cynicism. And the third component is lack of efficacy, that people in the workplace feel that they have no success in being effective in their work, a low sense of personal accomplishment. So that's the word that's used, and the consequences can be dire. And the consequences are seen in both the personal realm and the professional realm. Now this comes from Shanafelt and Noseworthy at the Mayo Clinic. The Mayo Clinic is really at the forefront of research in physician wellness. And you can see that the personal aspect, broken relationships, substance use, mental illness, depression and anxiety, and the worst possible outcome, suicide. But we know, and there's really, really strong evidence now, that when physicians are burned out and continue to work, there are very significant negative impacts on the work environment. There's decreased quality of care and no doubt about it, increased medical errors, medication errors, for instance, decreased patient satisfaction, decreased productivity, and difficulty retaining physicians, increased physician turnover. So, what is the rate? These are American figures. These all three studies come from the Mayo Clinic. And these are the figures that when you read an article, they tend to be the figures that are quoted because Dyrbye and Shanafelt are really the gurus of research. And the numbers that you'll see quoted are 30 to 65%. So you can see in 2011, 14, and 15, as they were doing their studies, and they surveyed every physician across the states. They had a 29% response rate. These figures were, the number of respondents was substantial, and this is the rate of burnout. If you think about the consequence of burnout that I described, suicide being one of them, this has been long recognized in physicians that they have a high rate of suicide. And when compared to the general population, the males have a 40% higher rate of suicide compared to the general population. And females an astounding 130% higher than the general population. Now, if you see the reference there, this was a New England Journal of Medicine article in 2005. How long ago is that? That's 15 years ago. The number in that paper is 300 to 400 physicians die by suicide in the US each year. The fascinating thing to me, having traced this history over my 25 years, is that number hasn't changed. The number that is still occurring now is 300 to 400 physicians per year. So I'm having difficulty reconciling this huge increase in burnout, and the suicide rate is not changing. And we know the number of physicians has increased. So that, for me, and I'm 2020 and where are we going, that's a question that needs to be explored from my perspective. And is burnout actually related to suicide, or is burnout related to depression and mental illness, which then in turn leads to suicide? So I'm trying to get my head around that thinking. Now let's look at Canada. Although I'll just say that the suicide rate in Canada is not tracked at all. We have no data on physician suicide in Canada. So in 2003, the Canadian Medical Association did a study of Canadian physicians, and at that time, 45.7% were reported as at an advanced stage of burnout. And this was the highest age group, sort of late early, if that makes sense. Not just at the outset of your career, but it's more into the middling of the career, if you think 35 to 54. And at that point in time, there was no difference between family docs and specialists. But in 2017, the Canadian Medical Association said we need some more recent data, and particularly because we were using American data in all of our presentations and talks. And so in July of 2017, they did a very extensive survey of physicians and residents in Canada. Now, anybody who's a researcher here would think, should you send out a survey to physicians and residents in July? Probably not. Not ideal. And so as a result, they had an 8% return rate, which was very low and very disappointing. But actually, in keeping with what you would think if you stepped back and thought about it. And I'm sure the Canadian Medical Association doesn't have that calendar fixed the way we do in medical schools. Anyway, there were some very good outcomes from that. Overall mental health, 58% of the respondents said they were flourishing. Well-being, 87% said their emotional well-being was high. Socially, their well-being was high for 65%. Psychological well-being, over 80%, and resilience, 82%. So across the board, pretty good results. But then in terms of burnout, and they screened, so this is an issue that I have, as I've said about burnout. They asked 2 questions about burnout and made their determination based on 2 questions. And their screening was not what a psychiatrist would do for a screening of depression, but these are their results. So they're lower. You can see that 26% had high emotional exhaustion, so that was the first domain. 15% had high depersonalization. And then they said, because of those 2 items, 30% overall were burned out. Not a good number, but definitely lower than the 45.7% they had in 2003. But 34% screened as depressed. And this number, 8% had thought about suicide in the last 12 months, and 19% have a lifetime incidence of thinking about suicide. Those numbers are much higher than the general population. There are international numbers about lifetime prevalence, and they tend to range from about 5% in some countries to 12%. And 12% is considered high. So if you take physicians at 19% who've thought about suicide during their life, that is a high number. And this I know you can't see, so I'm just going to highlight that, again, flourishing. This is divided into residents and practicing physicians. That you can see 58% of practicing physicians and 53% of residents describe themselves as flourishing. Low emotional well-being, 8% of practicing physicians, that's not too bad. Higher in residents, 12%. The burnout, 29% in practicing clinicians, 38% in residents. And finally, the lifetime suicidal ideation, as I said, the overall was 19%. Lower, a little lower for practicing clinicians, and look at this, 27% for our resident population. What has been identified, and I completely agree with that, is it's not just in the physician population that the incidence of depression and anxiety, and we think about the Queen's campus, and we know that to be true, compared to when I was an undergrad at Queen's University, the number of students who are accessing mental health counseling and support, the number of accommodations in our exams is just skyrocketing, so that's a really good point. Burnout rates in medical students. So I've showed you practicing physicians and residents, and we do not have any Canadian data on medical students in Canada. The Canadian Federation of Medical Students has done a lot of work in that area, but there's nothing published with their data. So this is American data, and again, it's all by Liselott Dyrbye from the Mayo Clinic. And she looked at 7 different medical schools when she did these 3 studies. So it's not one medical school, it's 7 different schools that participated. And you can see their burnout rate is increasing, which is actually interesting then to reflect on, is it a generational thing that's happening versus what is happening with medical students or residents? That's a great point. So I'm going to just speak to you about my dilemma, because I'm heavily invested in doing this work, and I believe it's very important, but I am concerned as an academic, as a researcher, about what are we doing calling everything burnout. And we don't really know what the link is between burnout and then worse ill health, or what the path from burnout, how to mediate it or remediate it so that someone goes on one path to better health versus poorer health. And this is a systematic review that was published in late 2018. And they did a systematic review looking at physician burnout. So this is physician burnout, not burnout across all different professions. And there were 182 studies from 1991 to 2018. And their conclusion was the findings preclude definitive conclusions about the prevalence of burnout in physicians. Because each of these studies, not each of these, that's a gross generalizing, that's inaccurate. So many of these studies take burnout inventories and pick out which items they're going to measure. And therefore, there's no consistent definition, there's no consistency in how we approach it, and so our findings aren't necessarily solid, founded in good science. So that has been my concern. So I'm in this ambivalent position in these years now of going, what are we saying? We're generating this incredible anxiety about the state of physician health as we're quoting these numbers of 65% of physicians are burned out. When is that the case? But nonetheless, we do know, and this is a 2012 article, we do know that when we compare burnout rates in physicians compared to the general population, and when compared to people who are of similar education, so a bachelor's degree, a master's degree, or a professional degree in something other than medicine, the rates for physicians are higher. So I don't know if that speaks to your question or point. It still speaks to our profession is at risk. So it's a critical issue in healthcare. The burnout rate, I've now seen a number of papers that are actually describing this as an epidemic. And you know what's happening with the coronavirus as we talk about the pandemic or the epidemic. People get very anxious about that. So I'm not sure we should be speaking about this as an epidemic, but nonetheless, that is the language that's being used. We do know that physicians who are not well, whether they're burned out or have another illness, it impacts on the quality of care. So that's crucial to me. And we do know that it has an impact on our students and residents, and therefore an impact on our future healthcare system. So I've spoken to you a little bit about my ambivalence and my ambiguous position that I'm sitting in, but I do believe it's a critical issue. So everybody's getting involved. I talked about the CMA survey. In 2018, following their survey and the results that they had, they came out with their new policy on physician wellness. And what they have recommended, and these are the implications for us at Queen's, training programs, hospitals, and other workplaces must ensure appropriate programs, services, and policies are developed in place and enforced for physicians and learners to get help to manage health and behavioral issues, support the need for treatment, and facilitate a return to work or training, while also protecting individual confidentiality, as well as helping the institution manage risk. And helping the institution manage risk is about, if you know that your physicians are not well and you know it's impacting their quality of care, what is the institution doing to mitigate that risk of poorer quality of care? So the CMA has said it's up to all of us involved in training programs and delivery of care to put something into place to address this serious situation. I'm going to change tack a little bit. I'm going to bring it down a little bit from the national situation to think about some work I've been doing recently with the Royal College. People in this room would be well aware that in 2015, the Royal College refreshed the CanMEDS framework. And one of the important things, two really aspects that were really given a lot of attention were quality and safety, and the second one being physician health. It was given a lot of attention that hadn't been in the previous 2005 framework. I was co-chair of the professional role and chaired the working group for physician health, and these were the new key and enabling competencies that are now in the 2015 framework. It's very interesting to do a whole lot of work and come up with 4 little sentences. But that's what we did. The key competency is that physicians are able to demonstrate a commitment to physician health and well-being, to foster optimal patient care. And then there are 3 enabling competencies about self-awareness. Each person can exhibit self-awareness and manage the influences on their personal well-being and professional performance. They can manage personal and professional demands for a sustainable practice throughout the physician life cycle. And third, promote a culture that recognizes, supports, and responds effectively to our colleagues in need. So that's the framework. But after we established the framework and with the new key and enabling competencies, the Royal College quite rightly said, well, what are programs going to do about this? We said that these are the competencies. This is what a finishing resident, a competent physician should be able to demonstrate. How are the programs going to do that? So I was asked to chair a task force for the Royal College to look at establishing guidelines that a program might use, and then the Royal College would in turn think about this as perhaps, and it's not a definite, perhaps think about the guidelines as accreditation standards. So we had a small task force, 7 people who worked very hard for the last 2 years. Amber Hastings Truelove is in the audience. She's worked diligently on this project. And then we had an advisory committee. So any of the work that we did, we ran it past our advisory committee. Our advisory committee, and you may recognize if you know physician health personnel at all, Joy Albuquerque, who's now the director of the Physician Health Program for the Ontario Medical Association, Mamta Gautam, who's been from Ottawa, who is a Canadian lead in physician wellness, Jane Lemaire in Alberta, who's a lead, Michael Kaufman, so UBC. So really we went across the country trying to engage experts in physician wellness to participate in this. It was a very long process, as I say, and this is what we did. This is why it took us time. We started with an environmental scan. We went to every one of the 17 medical schools across the country and said, what are you doing currently in your undergraduate medical education program, in your residency programs to promote and support physician wellness curriculum, assessment, training? What are you doing? So that took quite a bit of time, and it was fascinating. Every school was doing something. There's no doubt about that. But the one that Amber will laugh when I say, the one that always struck me as, why would someone be doing this? Pet therapy is offered at one of our medical schools for students. And I'm going, where's the evidence for pet therapy? Not that I don't think on campuses, and I know that on campuses they have days where they bring dogs in, and it's a very social, wonderful kind of experience. But in terms of a program with evidence that it supports, that's what we should be doing. Is there any evidence for that? But there were lots of things, particularly around mindfulness-based stress reduction, resilience type of training. So, lots being done, all different kinds of things, all incredibly well-intentioned. And then we did a scoping literature review, and I will not walk you through the methodology, but we have the methodology and we put it in our report, which took us a huge amount of time and work to look at what are the things that are being offered that have evidence-based, that they should be included in programming, or if not evidence-based, at least evidence-informed. They were selected as programming offerings because there's some evidence that that's an effective thing to do. And I will tell you that pet therapy wasn't found in our literature. Then we, as I said, we consulted with our advisory group, and then we did some crowdsourcing. We went to 2 different conferences in 2018, the International Conference on Physician Health and the International Conference on Residency Education. And we presented our findings, what our recommendations, what the things we found in the literature and were being used that we thought had some evidence to include in a program. And then as well, what were the guidelines that we were coming up with? Did they resonate with people? Did they think, yeah, these are sound, and yes, these are plausible, and yes, a program could do them? So lots of feedback from people who are on the ground, both in physician health programs as well as educational residency education programs. And I think this is important to say we had some guiding principles upon which we based our work. It is our belief that physician wellness is an essential and evidence-based aspect of medical education practice and quality patient care. It's an important phase for physicians all through the life cycle, not simply for medical students or residents, but needs to include practicing physicians, and then see them through to retirement. This was really important to us, that a lot of people get their back up when they think about physician health because they see it as programming that's delivered to an individual, and they almost see that as victim blaming. So if a program, for instance, says, let's have a session on meditation-based, mindfulness-based stress reduction. People who are on the receiving end often feel that that's sort of victim blaming. If I'm tired, if I'm exhausted, if I'm fatigued, it's not my fault. So it's became really clear to us in our work that this is incredibly important, that it's not simply about programs that are offered to the individuals. It has to include programs, it has to include programs that the leadership of organizations take on and champion, that there has to be, from the C-suite as they call it, an acknowledgement that this is important. And that was something that really has come out in the past 2 years, I would say. It's a shared responsibility. Physician wellness requires commitment and engagement from stakeholders across the system to optimize physician health and well-being, and once again, our collective responsibility. So those were the principles upon which we based all of our work. We came up with, and I'm just going to go through this quickly, we came up with 15 recommendations that we built into a one-page chart. Overarching is the key competency, and then our 3 enabling competencies. And what we thought in terms of the enabling competencies is This first one is really about education and skills. This one is thinking about sustainability of your health and well-being. And this one is thinking about what supports are required. So we put that together in terms of, if I'm going to go back, if we think about education and skill development, then we have to think about building awareness and skill development. Sustainability is about how do people maintain their wellness. And finally, what supports are needed when someone's in distress? What is the response and management of the organization? So we came up with this, and again, we just emphasized that wellness requires the culture, the profession, the environment, and the individual need to be thinking about education for all. We need, for maintenance and for sustainability and support, you need policies and programming. You need champions. So that's how we built it over time, and we came up with our 15 recommendations. And we now have this one-page table with our 15 recommendations, and that's how it all fell out. It's our recommendations at a glance for a program. We used wording such as programming exists for this, and we did that because that would be the aspiration. This is the ideal. Programming exists, so let's take this one. Educational programming exists to build awareness around physician wellness at every stage of the life cycle. So we wanted people to be able to look at the recommendation and go, oh yes, we do that. Or, oh no, that's a gap in our program, we don't do that. Those are fine as recommendations, but if you don't know the literature, and I don't have a copy of it, but what we did then was we have on our template, underneath each one of the recommendations, we have a further 2 or 3 page document which puts all of the suggestions that we found in the literature of what you might possibly implement at your institution or in your program to start some programs. So, the good news for Amber and I is that we submitted the final report. It's called Creating a Culture of Wellness in Medical Education and Practice, Recommendations from a Royal College National Task Force. We have submitted that report. It's now going to work its way through the Royal College, and they will determine whether they use it for accreditation, whether they will simply use it as guidelines, some advice, some suggestions for their programs, and that is yet to be determined. In the CAN-MIDS framework, they're considered key and enabling competencies for a graduating, finishing physician, but as individual competencies, they're not necessarily assessed, nor certainly considered in terms of accreditation guidelines. So that was a really interesting question, actually, for the task force and the advisory committee, and we went back and forth whether we would recommend to have a program accredited, you must meet X number of these recommendations. And we really didn't think that that was within our purview. We were making the recommendations, trying to give people some guidelines, and we didn't think it was we didn't have the authority to say, we think you should every program should have at least 3. It just felt beyond our purview, as I say. So that's why it will go through this process now at the Royal College, and they will determine. And I'm just going to go back. That looks so simple and so clean, but I can imagine if you're not familiar with the field, how you might go, programming exists to teach skills to enhance wellness. Well, how the heck am I supposed to do that? But we have a menu under each one of those recommendations of what you might do. We actually first shared the document at ICRE in 2019 in the fall, but it has been embargoed until that release. Because it hasn't been published yet, the Royal College has asked that it not be shared widely. So it's a bit difficult because you actually need the text, I think, of the document to understand how it all is going to work. But I think there they're afraid, especially because the advisory committee, they're all people who are engaged in this field and go, this is such a great document. We could use this at our organization. And so I think the Royal College is afraid that it will get out in front of them. So at this point, we've been allowed to share this information, but the document itself is embargoed. So, big, smaller, let's come home. School of Medicine, what does wellness look like? And this is about the response to the increasing concern about physician burnout. In late 2016, when we established a new strategic plan for the School of Medicine, one of the goals that we actually built into the School of Medicine strategic plan, one of the goals is we will promote a culture of wellness. Well, I can tell you that it's easier to say that than to do that. It's very difficult to go, I'm just going to promote a culture of wellness. So our strategic plan does have some measures of success, and one was perform a needs assessment, and the section was to establish a committee to advance concepts. So within year 1 and 2 we would do that, and then we'd move there. We are now in 2020, so we're moving here. And I will say that was the strategic plan. The other thing that really gave us momentum to do some work was the CMO governance retreat in the fall of 2018. So this was a retreat with the CMO management and all of the department chairs, and each department chair was invited to bring at least one other department member to the retreat. And over again, the department chair said, we are so concerned about the state of our physicians' health. We need to do something about this here at Queen's. So we have the strategic plan that says we're going to do something, and we have the department chairs. It came out loud and clear that this had to be addressed here at Queen's. So I was charged with taking the lead on doing something about this. And so we decided, I created a small research team. 2 of my team members are here, Amber Hastings, Claire Wearsink, a Queen's student who worked with us on this study, on this work. And we surveyed people, and many of you in the room would have participated in the survey. We distributed the survey in late May through June of 2019. We used the Maslow Burnout Inventory Toolkit, and we use that one. You'll go back to what I said. I'm concerned about how people are measuring burnout across multiple different institutions and organizations. We use that because it is considered the gold standard. I had a number of respondents say, well, that wasn't great for us. It's an American tool and it didn't fit very well for us here at Queen's. But because it was the gold standard and we thought it the best tool to use, it also included the areas of work-life survey. And we distributed it in June to our medical students, our residents, and our faculty. And then we invited people who might be interested if they wanted to participate in an interview. And we were very pleased with our response. We had a response rate of 412 overall. That's all 3 categories, which was 30%. So for a survey, it's not at all bad. 25% of the medical students, 23% of the residents, and 57% of our faculty members responded, which we were really pleased about that. And then, as you can see, 13 interviews were conducted. This is really important, I think, to look at before we look at the results. Because when reports of physician wellness are spoken about, they always talk about the burnout aspect. But the Maslow Burnout Inventory actually measures different aspects, different things. It measures how well engaged people are, or if people are feeling ineffective, or overextended, or disengaged, or burnout. And I'm just going to walk you through. If you look at emotional exhaustion, depersonalization, and personal accomplishment, those are the 3 domains of the burnout inventory, right? We talked about that. And if you have a very low score on emotional exhaustion, I'll tell you the survey itself is 22 items, so 22 items, and if they're put together and you're low on emotional exhaustion and low on depersonalization and high on personal accomplishment, you're actually measured as engaged. And very few papers actually report on all of these different domains. They report on burnout, which is if you're high in emotional exhaustion and high on depersonalization, you're considered to be burned out. So that's really important aspect. Okay, what did we find here at Queen's? These are the 3 domains: emotional exhaustion, depersonalization, and personal accomplishment. If you're higher on emotional exhaustion and depersonalization, you remember high on those 2, you're burned out. This is our overall group is red. So this is Queen's in red. This is Queen's, this is students, residents, faculty members. And this is a comparator that we're given with 11,000 different health services personnel. So when you do the survey, you're actually given that comparator group. So you can see in terms of depersonalization, our residents are much higher than a control group. Emotional exhaustion as well. I'll put it into burnout, just the profile. If you look here, you can see that the medical students, and this is just by number, it's not percentage, 132 people were engaged in our residents, students, and faculty. 75 people, medical students, residents, and faculty, are identified as burned out. So it's important to see these numbers as well as this number. And then this is what is statistically significant. That for medical students, interesting, medical students, 31% feel ineffective. But that's not statistically significant for residents or faculty. For overextended, statistically significant, our faculty are overextended. And burned out, it's our resident group. This one I thought was important, the perception of institutional support by the different cohorts. Interestingly, that 132 of those people who were engaged, remember 132 were engaged, the great majority said yes, they feel support by their institution. So that's actually makes a little sense, doesn't it? If you feel supported, you're more likely to be engaged. We'll go down to burnout. There are 75, but still many of them felt supported by their institution versus not supported by their institution. And then I'll just give you the statistics about that one. So perception of institutional support, those who are engaged, those who felt supported, it's statistically significant that those who felt supported are also engaged. It's also those who felt unsupported had a high rate of feeling overextended. And this one is very interesting. Because it's come through to us over and over again that so many of our faculty members, residents, and students don't have a family physician, we wondered if that made any difference in terms of their wellness. And that's the yes and no for do you have a family physician? And this is the piece that was really surprising to me. It's surprising, not maybe if you think about it, but surprising to actually have it jump out that those people who identify as burned out in the survey, it's statistically significant that 27% of them don't have a family physician. And you just wonder about that role, about accessing care, getting support when you need it, getting regular care. It's a very interesting statistic for me. Then there were some opportunities for not just for people to give narrative responses. And what Claire worked the summer doing for us is this is from the paper that Shanafelt and Noseworthy published that I alluded to, that we showed earlier. And they have come up with a paper, their paper, which is about organizational strategies to address burnout in the workplace. And they have said there are drivers of dementia. And they're either, if they're not optimal, they lead to burnout. But if you make sure they're well taken care of, they actually lead to the engagement. And their workload and job demands, control and flexibility, efficiency and resources, meaning in work, the culture and the values of the organization, work-life integration, and whether there's social support and community at work. And they've said those 7 items make the difference between your population, whether they're burned out or whether they're engaged. So they say this is where the money should be. So we had narrative comments. We did the analysis of our comments looking at where those comments fit in terms of these drivers. And people overwhelmingly said the things that promote well-being are social support and community at work, work-life integration, and control, some sense of control and flexibility in my ability to do my work. The numbers are the number of comments that we had about those 3 domains. We also looked at what are the identified factors that hinder well-being at work. And number 1, far and away, out of 412 people, 378 people said workloads and job demands. And interesting, social support and community. And the comments that were under social support and community were about interpersonal conflicts, difficulties with the people with whom we work at. So it was interesting that that also came in as something that hindered well-being. And then the very common concern about sufficient resources to actually do our work. And I said sufficient resources, but it's also that efficiency. What am I as a physician doing all of this paperwork when perhaps I should be using my skills in another different domain? So I wanted to show you, and I'm now in a position, I'm sort of at the end of my talk, some of the quotes, or whether you want to have a few minutes of discussion. There are some really interesting quotes that these came from the individual interviews. So we know that the 13 people who volunteered to interview had some whatever personal desire to express themselves. So it's not necessarily a reflection of the whole group, but there are some really interesting things, I thought, in terms of cultures and value. And these quotes are from some faculty members. And the second and the third one are of concern to me. This whole notion that you're promoting this sense of wellness and a culture of wellness in medical students and in residents is false. Once you get into the real world, no one cares how you feel. And the third one, no, I don't think there's a culture of promoting physician wellness. It often feels that there's a culture of physician blaming. And I'm going to contrast that with the students. Wellness is very much a pervasive concept in the medical curriculum. It's a concept that students think about all the time. Among students, there's an open culture of talking about wellness, which I think is positive. I think Queen's has gone well above and beyond the school in terms of promoting wellness. So a very distinct difference in terms of thinking about culture and values between our medical student group and our faculty. And then I have a couple from residents. And this is one that's, people like to talk about it in talks and sessions. So yeah, they're promoting it and encouraging it, but follow through, not so much. Or this one, we need to stop having committees and events and workshops. We need to have more understanding. But that community, that social support is crucially important to every group. The collegiality of the faculty at Queen's is the only thing that makes it worth doing all of this work. And then again, we're lucky because there's great collegiality and a sense of community. Students and residents, the school is very supportive when it comes to wellness. And we all know about the low threshold to meet with a wellness advisor. And then the residents said, I think most of the support comes from other residents. So I've taken you from sort of the field of physician health to my involvement in some projects with physician health and brought it right home to where we are and where we work. And to me, there are many, many more questions that need to be asked. I think we need some sense of consistency about what we're actually talking about. That doesn't mean that I don't think this is a serious problem, because I do, but I don't think we've identified it clearly. And is there a path that someone gets fatigued and then burned out and then depressed and then suicidal? Is that a path, or is it just happenstance or serendipity? And I don't know the answer to that. But my concern about using the rates of burnout that we're using is it's not helping us actually make those determinations. So there's lots of work to be done. And one of the things that we've done that we're very excited about, but have no idea whether it will come to fruition, is I've been involved in putting a grant forward to perhaps get a chair in physician wellness for the School of Medicine, somebody who would actually take this on as their job and move the strategic plan forward and take some of the results that we have. We know now where our real areas of need are. Take this forward for their, if not their full-time job, maybe a concentrated effort in terms of addressing the issue. One thing I'm very clear on, physician health is not just an individual problem, it's an organizational and systemic problem. This is a previous president of the Canadian Medical Association who said that. But I'm also going to say, and I believe this very strongly, that it's not simply an organizational and systemic issue. It is also about preparing our students and residents for very difficult, stressful work. And how do we prepare them to do this job? I think we face challenges. I always hear about, well, if I go and see somebody, who's going to know about that? Confidentiality. Resources are a big question. Preferential access. Should physicians get access to mental health care prior to our general population, who we all know are in need of mental health care at a rate that is unprecedented? And there is something really important about caring for colleagues. You need to have some skill development in doing it, because it's very challenging work to respect your colleague, but also not to change the way you practice because you're delivering care to a colleague. So I think that stress is inevitable in our work, but I think we have to be a caring organization and continue to advance our attempts, our desire to provide care to those who are burned out or who are unwell, or to help prevent people from going down that path. So those are the things I said I would tell you about. I've walked you through 25 years of work, and I thank you for your attention.